Hi, my name is Jackie Davis. I'm the Executive Director of the Mental Health Association of the Eastern Shore. We're providing a series of talks over this summer just about various topics with regard to mental health in our community. Today, our guest is Rob Schmidt, Dr. Rob Schmidt, I guess I should say. I'm going to let him just briefly tell us a little bit about himself and the work that he does within that school system. So welcome, Rob. I'm really glad you're here to join us today.
Thanks for this opportunity. Actually, I work as a behavioral specialist for Talbot County Public Schools.
Okay.
And pretty much oversee the school mental health program and the Yellow Ribbon Suicide Prevention Program, and work as a Section 504 coordinator.
Okay, very good. Well, we're delighted that you are here today to join us. And I know, though, that your specialty or area that you really have focused on, I believe your professional career has been suicide assessment. So if you don't mind, go ahead and tell us a little bit about, we'll get into the details here in just a moment, but just about you just had your PhD, and that was on the suicide assessment that you developed. So briefly tell us about that, and then I have a few questions that we'll get started with.
Okay. The name of the assessment is it came out in 2009. It's called the Risk Identification Suicide Kit, and this summer will be coming out the Risk 2 for short. And that was to augment pieces that were missing in mental health practitioners, I guess, in graduate school, lack of training, sadly.
And I know that you have, and I think it's something that the audience is important to be aware of, and that is that you have said, because I've gone to your trainings, you have said that in the process of becoming a therapist, a counselor, and a social worker, that suicide assessment is really not, I guess unless you take a class in it, it's really not something that is taught.
No, it's not. In fact, in most graduate programs, including like the PhD programs around the country, it's only over a couple year period, maybe a few hours given. And in some programs, it's as little as a half hour. Wow. And it pretty much describes to you what to do if somebody's either suicidal or homicidal when they talk about the Terror Assault Act. And pretty much what that is duty to warn if you know of anyone that's threatening themselves, harm to themselves or others, that this is what you do or act and how you act in a duty of your profession.
Okay.
To prevent someone from being harmed or someone harming themselves. But as far as suicide assessment, it's probably the most overlooked part of any curriculum around the country, and that's where I did a lot of research and publication in. And the unfortunate thing is that when we do send someone, for example, to a hospital in Maryland or on the Eastern Shore here on our 9 counties on the shore, is that the hospital there's nothing magical about inpatient anywhere if the hospital decides to send someone to an inpatient. On average, it really much depends on the insurance, and it's anywhere from 2 to 3, maybe a 4-7-day stay, but there's nothing magical about that time other than it allows for the youth or the adult to have what's called a cooling off period to get back on track, since it is, when someone's suicidal, it's a high intense emotion, usually lasts in short duration. And the hospital allows, or hospitalization or inpatient allows for that child or for that adult to have that cooling off period to regroup under a supervised setting. Going back to the risk assessment is what you had talked about earlier a few minutes ago, is that since we haven't received social workers, school psychologists, licensed professional counselors, right, it allows them, it's a guided structured assessment in an interview form, and it covers 8 different compartments. It's open-faced, so it's easy if you've never been trained in it to walk through it, and it comes with a manual.
Okay.
That helps guide if you've never done assessment, and the training also would come with that.
Okay.
Just to ensure, because it's a legal document, anytime you're assessing someone for suicide, the purpose of a suicide assessment is going to lead in either two directions. It's going to lead the child or the adult and family on a path to recovery, or it could possibly lead to death. And those are the 2 avenues when we do an assessment. And it's scary, you know.
I'm sure.
despite the level of training. You should comfortably, confidently, but yet again feeling insecure. Some people that have gotten training or some people that think they have training are overconfident and they make a lot of errors, thinking that they know what they're talking about and will ask some simple questions. And they make a lot of errors, what we found in research. And so those errors can come back and really haunt you and possibly cause a catastrophic event in the family or community.
Wow. Well, we're going to delve a little bit farther into the assessments a little bit later. Right now, if we would mind sort of changing gears a little bit, and first, I'd like you to talk about your talking to parents right now. Just say you have an audience here of parents and you want to try to give them some advice, some things to look for in their child that is in middle school, high school, assuming we're not talking elementary school, but if we are, please include that. So if you're talking to parents, what are some signs, symptoms that maybe they should look for, pay attention to when their child comes home from school? And then a little bit later, we'll go into resources and where people can call if they're concerned about their child. So if you wouldn't mind right now, just sort of pretend you got an audience of parents here, your school parents, and you really want to try to impart some advice to them as to what the things to pay attention to.
Well, it's complicated because it varies developmentally,
Okay.
and so it's important across the board that like teachers get the amount of training, but elementary school, a lot of kids will say, I wish I was dead. And that is up to grades 5, what we typically see. I wish I was dead.
But that's not, is that like a normal?
Well, it's hard. Saying that is never considered like a normal coping skill or venting, especially since they don't know the finality of it, of that you can't bounce back. It's not like the Bugs Bunny Roadrunner that age where you get smashed by a boulder and you pop back up and then you go to lunch class.
Right.
It doesn't work that way. And they don't understand that. However, anytime that it's said, regardless of the age, it needs to be taken serious from parents and look into, why did you say, what was the reasoning or like precipitating factors that caused that? It's typically not a normal reaction or response at any age. Middle school, what we see more so, and we see a lot of self-identifiers, sometimes in writing literature for the English teachers, pick up some things in writing some papers, which is incredible for them to even have that training or receive that training. A lot of students will make impulsive statements with no intent to harm themselves. However, it's hard to delineate that. Whether it's a school or a community or a home setting, and for parents it's very difficult because are parents aware that their children are even thinking about this? Are they even aware, most importantly, what is being texted from their phones or what's being sent through Snapchat, which we find so much information on Snapchat, on the phone.
What is Snapchat?
It's, from what I understand, because I'm not on the cutting edge of that technology, is that I think it's posted within a 24-hour period where you could see it and it vanishes.
Okay.
It goes away. However, you can take a picture of it on your phone and keep that posting.
Okay.
Because what we're seeing a lot of my son's at this school, this girl's at this school, they break up and they're texting back and forth. You're going to miss me. I hate you. And what we see is at different grades, there are different levels of reasons for having thoughts of suicide. I'm bouncing around.
No,
but
you're doing well. No, that's answering the question.
But what we find, like 12th grade, the biggest reason, and I did a study, it was published in the Oxford Journal of Children in Schools, and what we found in 12th grade of over 6,000 students from the Mid-Atlantic area is that breakup with boyfriend was the number one reason, tied with family problems.
Okay.
And family problems, there are subcategories of family problems. It could be divorce and separation, which is devastating. Breakups, parents taking a break. It could be that there's already a separation that, the there's no good and goodbye, but one parent is blaming the other in front while the child is at their home. And this is generic. This is across the country. And then there are some others that we see is that, I'm going to pick my son up on Friday. I never show or call, and they're packed to go with me, and I don't show.
Wow. Yep.
And then from that, you have in grades 11 all the way down through grade 6. The study was grade 6 through 12. And the number one reason by far, I know everybody thinks it's bullying, but bullying was actually ranked third on the list. It was family problems, number one, and grief and loss, and then bullying, and then it varied down. But in almost, of that study of almost 6,000 students, there were 673 that actually had thoughts of hurting themselves within the past year, and 77 within the past day or two.
Wow.
And it was pretty common, the reasons for these precipitating events, and mostly related to the family problems.
Wow.
So.
Okay, so, well, and again, back to maybe some things that we might see that would be cause for concern. You had mentioned that if they were talking about, I want to kill myself. So that certainly should be something that should spur a conversation with your child.
Sure, and then tearfulness, I'm going along the signs of depression, so you're looking at any changes in behavior that are picked up. Parents, if your son or daughter is not so much involved in things that they used to be involved in, so they're pulling back. If they are staying home or not going outside as much, if there's a change in appetite. Some people, again, depression or depressive type symptoms affect everyone differently. So I may overeat or may not be able to eat. I may sleep too much. I may not be able to sleep. So the ruminating thoughts of why I feel this way, I may not be able to shut my brain off, so therefore I can't sleep. Whereas if I'm really depressed, for other people, it might be that I'm just using sleep as an escape or coping mechanism, so I'm kind of escaping from the world without the involvement of drugs. However, the involvement of drugs is a whole nother category.
Just complicates it.
And it really makes a situation that is fixable that much more complicated to fix because you're bringing in other elements. So when you look at all the symptoms related to it, you're looking at mainly symptoms related to, depression. I've never interviewed someone, maybe once, after they had already made that final decision, that were happy. So, teachers, training teachers to look for changes in grades, attendance, increase in disciplinary referrals. And there's a difference between boys and girls. What we see mostly in a regular school setting, that is grades 12 and below. So we're looking at boys more so externalize their depression, not all the time, but in most cases.
What does that mean, externalize?
Externalizing is that you're starting to see more outwardly signs of depression, more irritableness. You're seeing maybe Rob didn't fight before, but now he's getting involved in more so risk-taking behaviors. So I'm showing my anger and depression more so what we see in girls, more withdrawn and more tearfulness and more emotional. And it's really important to see that. And it's really important that school staff receive a training in mental health. And we'll touch base on that, I know, because teachers spend so much waking time with children, more so than a lot of times than parents during the course of the school year for 10 months. And so they see changes in behavior, and they see these grades drop. They were able to see changes in behaviors with disciplinary referrals, and not so much that. And it doesn't have to be a disciplinary referral, but any changes in behavior where you're seeing some irritableness or withdrawn symptoms, tearful or emotional symptoms. Not so much really interested in sports any longer if they're on a sports team. Skipping lunch, not really eating at lunch, loss of appetite.
Right.
Coming in late to school, why is there an increase in tardiness, So those...
Is it true that if someone is really considering suicide, that they start giving away their things? I've heard that said.
Well, giving away prized possessions is one of the main...
Does that tend to be like a younger age type of thing, or that can be at any age type of
Well,
thing?
younger age is not so much cognitively developed enough to think about the future of that. More so like high school and adults want things to be taken care of when I'm not here.
Okay.
So that planning is taking effect. And Usually in suicide, the word I want to kill myself is very rarely used, but there are a lot of innuendos that are given.
Okay.
And those innuendos was like, well, who cares? Nobody's even going to care if I'm not even here anymore. Who's going to, what's it matter to you if I'm not here? You know, who cares if I'm not here anymore? Who's going to even notice? Don't worry about seeing me next week because I'm not going to be here. You know, those kinds of things. Or any futuristic types of plannings, more so in the older population. I'm saying like, you know, grades 9 and above all the way up to adulthood. And the rate of suicide is increasing quite a bit over the past couple of years. I mean, it hasn't stopped. It's been on a gigantic incline since the 1950s. And we really have not seen a whole lot of a decline. In fact, right now, it's almost 45,000 people per year, with almost 6,000 of them being, you know, youth.
45,000 a year and
Of that, about 6,000 are considered are youth.
Because the highest rate of suicide is actually, is it males between 45 and 64?
Well, it's 45 and
something?
54.
Oh, 54.
And then
okay.
second is 85 and above.
Right.
And then below that would be ages 15 to 19, which is
Okay.
ranked third.
That's ranked third.
Yeah,
Wow, okay.
right now, and it's increasing, sadly.
Okay.
You know, and so, you know, when we think about the continuum of suicide, it was always thought of as that it's an impulsive act, but what we find that it's much more premeditated and much more thought. And giving away prized possessions is a good example of that. You know, can you take care of my signed Johnny Unitas helmet? And the question is, well, where are you going?
Right.
You know, what are you doing with that? And can you take care of the keys to my car? So, warning signs are given, and this data that I'm about to give is the same exact data that coincides with like an active shooter, is that warning signs are given up to 3 months in advance. Friends know about it, and 9 out of 10 suicides, friends knew about it well in advance. But why don't they say? And the thing is, you know, it's the sworn to secrecy. Please don't tell anybody.
Right.
You know, if you tell anybody, I'll never be your friend again.
Right.
I'll hate you forever. You know, those kinds of things. But what we need to look at is we need to empower peers and adults to say, hey, it's okay to ask for help, to talk about it. Because if you don't say anything, and that's one of the things I say to parents and kids, because parents are also are given innuendos, like, I'm not going to go to camp this summer. Well, why not? You know, or I'm not going to do this, or I'm not going to do that. That subtle withdrawal. Too often as adults, we're too busy to ask and take a break and say, hey, you know, why are you doing this? You know,
Right.
why aren't you doing it? Why aren't you excited about going here? Why aren't you excited about going to your dad's again, or going to your mom's, or camp, or school? What? And those questions are not being asked as they once were. And so we're seeing a steady increase in the suicide rate, and we're seeing a deterioration of coping skills. And so the more apt to ending the problem once and for all versus dealing with it, because it's thought of, you know, when we think about like what keeps us going. So why, when you get dumped by your boyfriend, why are you able to go on and say, okay, no problem, the next one, I'll go after the next one. So, and where I'm dumped,
Right,
and I
and-
want to kill myself.
right, and
And we
you're
looked at that level of coping skills that each of us have, and the pain threshold that each one of us have. So when the pain exceeds our ability to cope is a gigantic problem, and that's where these warning signs come in. Okay. So these warning signs come in. So you might have what's called protective factors. And protective factors, it's also called like syndemics. It's a combination of a lot of different things in our life that keep us going, that gives us that resiliency through life's difficulties. Hey, life's difficult for all of us.
Exactly. We all have.
And we fool ourselves when we think that each one of us don't have a breaking point, because we all have a breaking point. However, why do some choose the route of ending a problem that is definitely fixable versus others jump into the quicksand and feel that like they can't do this anymore?
And that's that resiliency,
And that's
or the coping factors
and
you were talking
the coping
about.
factors are the
Right.
protective factors are, our church enrollment around the country is way down. We know that.
Right.
That's one of his hallmarks of protective factors. Having somebody at church, if it's not the clergy, it could be somebody at church that you see every day to ask just simply how you doing.
Right.
It's a breakdown of our families, which is, again, divorce rate is just about 50%, just over 50%. Schools, you know, it goes back to John Dewey in 1888 that created school mental health to have therapists and counselors in the school.
Right.
And that needs to continue growing. Again, protective factors, it could be our custodian at work, at school. It could be our cafeteria worker that simply asks, you know, that's a nice top you have on today. You know?
And that's one of the reasons that we try to emphasize doing mental health first aid, the youth version in our schools, is because that teaches part of that curriculum does and it's for the bus driver, the cafeteria worker, that training that we offer has. But unfortunately, it just doesn't seem to be a push from school systems or from MSDE to please and make it mandatory to go take this course, because we do offer it throughout the year. Happy to say that the Talbot County school nurses will be all attending the course in August. And so that before school starts again, so that'll be very helpful. But everybody that works with these kids, because it shows them how they can support the youth.
And identify early.
And identify things early.
For the need for mental health.
Yes.
Because we
Yes.
don't want we don't want our youth, even adults in outpatient settings, to get to the crisis mode, to the crisis situation, because there are so many flags that go up that lead to that crisis mode.
Right.
And so who's the pivotal people? Who are the people that, because
Kids
everyone in the
sees
school
every day.
system or everybody we have a role if we just take time to listen versus get into a tug of war where you think you have problems, you want to hear what happened to me, and
Right.
versus being a good active listener. You know, because everybody, especially in the school setting, has a role, whether they are aware of it or not. And it's, again, simply asking somebody how they're doing, complimenting them as you walk down the hall.
Right.
You know, those kinds of things. For most people, it may not mean a whole lot, but if you don't have a whole lot of those protective factors in your life, that means a lot that you actually noticed.
Right. I know one of the trainings that I've attended that you gave when you were teaching the assessment recently, you had a film there, a real short film there of the guy who was going to commit suicide, seriously thinking about committing suicide. And the one thing he said, the thing that stopped him that day was the lady, the friend's mother who made him a pie or a piece of pie just for him. I don't know if you remember that little
I believe
film.
it was a cherry pie, very important.
But, I mean, it was that one small act of kindness.
She invited
that sort
him
of got
over.
him out of
Right.
that thinking.
Right.
And
The
he
quicksand. It's in the quicksand.
Okay, and I used to refer to it as, not that I'm an expert on it, I'm not, but was that just like the zone, just like an athlete can get into a zone when they are performing or getting ready to perform at, that's what they're focused on. I understand it when you're really actively thinking about suicide. I mean, in really getting to that brink, you're in a zone.
Well, that's the last stage,
and so
right?
you something dramatically has to be done to snap you out of that zone, or you may very well go through with the act.
She invited him over, homemade cherry pie.
Yeah.
Before that invite, that night he was going to kill himself.
Yes.
And simple, kind gesture. Again, to him, it meant it was priceless.
Exactly.
For the average person, but no, I'm too busy, I'm okay.
Right.
And that saved his life, and now has a family and several children,
Yes.
and is just doing phenomenal.
Yes. Another thing I have learned just by going to trainings and educating my own self has been those who have did go through with the act to commit suicide, but they were not successful. And mainly it's the couple, the bridge jumpers that I have heard talk, and
Yes.
they have all, and that were saved. They have all commented that the instant they let go, they regretted that decision, and that their life mission. It was Kevin Hines was the one from the San Francisco bridge, and
Right.
then there was another. I don't know if it was in Pittsburgh or not, but somebody else who now will go and was trying to do talks and spread that message. They've recovered, they are healing, and now they feel very impassioned about sharing that message of getting help if you need it, because it was that moment, I guess it was the zone or that suicide, it snapped, but the moment they let go, they regretted that they had made that decision, even though it was too late, but thankfully their lives were saved, so.
Well, that's again, it's the suicide continuum, and it's the act of that. There's all these warning signs for help. I mean, all these signs are sent out there for help. No matter how subliminal they were not picked up. And this is where I'm at. And so the option for suicide comes in when the pain is so great, the psychological pain, it's called psych ache, where the pain is so great, I cannot take this anymore. So that leads me to that road of wanting to end it permanently. However, up until the time of that attempt, so that someone that does attempt suicide, I've done thousands of suicide assessments, and I've worked with a lot of people that have attempted suicide. They wanted to die up until the time they made that what they predispose in their brain as a final act. This is what I'm going to do. But survived, unbeknownst to their initial motive, but their motive was to end their pain, not so much to die. However, they felt like there was no way out. This is the only way out. And then they realized, after surviving these attempts, some multiple, which are chronic, they really just want to stop hurting. They want to escape the psychological pain. So they want to do an act to bring it all to a final closure. Even though that's probably not the best way of doing it, because what we find in the studies is that till the time they actually attempted it, they realized that they didn't want to die after they attempted the suicide. Work with a lot of people in general, females especially, related to taking pills, wanting to die. And they took the pills, realizing that they just made a mistake because they're starting to feel different, and called for help. So unfortunately, though, with the gun piece, is that it leaves no room for being saved.
Yeah.
You know, other methods right now, nationally, the suicide rate, the means of suicide, 51% of the completed suicides are related to use of a gun. 49% are related to other types of methods, suffocation, and hanging, and pills, for example, those kinds of things. Too often, though, we only get focused on guns when you have the equal amount of people also dying from other means. So now the sad part about this is that the suicide rate, say of the 45,000 people that died by suicide a few years back, and suicide data were always a couple years back. And so the sad part about this is the suicide rate is much higher because only 1 in 5 suicides are categorized from the medical examiner as an actual suicide. So the suicide rate is much higher unless there is a black and white distinction of the cause of death. It would be either coded as accidental, car accident, or an overdose. But the rate is much higher than 45,000 people, sadly. It's much higher.
Is that because of stigma or insurance or a little of both? Or
just
because of the way the laws or the...
It's a combination of everything that you just said.
Because
it is complicated to determine the cause of death and the motive behind it unless the person leaves a note or gives an innuendo prior leading up. And what's called a psychological autopsy is when you interview those people around closest to the person that died by suicide and figure out, did they say anything to you leading up to this? Has everything been okay? In adults, we see loss of a career or job or retirement is a chief motive also, in addition to financial for adults, as a chief cause of it. And so looking back and saying, hey, when we interview people in that family, they didn't leave a note, and there's a one-person single accident into a tree. Weather conditions were great. What led up to this? Was this just a car wreck, or was this, So how do we do these psychological autopsies for the amount of these types of what's perceived as accidents? The same thing with overdoses. So many people dying related to, the opioid epidemic, of course. And so what is the motive behind that? How much pain is really inside there? And very rarely a note is left when there's an overdose. So we classify it as an overdose, drug use. Well, what was the real motive of entering that altered state and seeking out drugs. What am I running from? What pain am I trying to suppress through this altered state that's only temporary, that
Right.
leads to the addiction?
So the 45,000 number could
Oh,
be
it's much higher. It's
than
the
what
6,000 of that related to youth. This is much greater. It's much greater.
Well, now would be a good time, if you would, I know you know it by heart, the Maryland suicide number. Why don't you say that you let our listeners know what that number is, please?
It used to be called the Maryland Youth Crisis Hotline, and it was for youth. And actually, Maryland, I have to say this, Maryland and Mr. Henry Westray, who's retired from the Department of Health and Mental Hygiene, the Maryland hotline number was actually the first hotline number in the nation.
Wow.
So, and that number still exists. However, they changed it to make it a hotline number, so it's no longer considered youth. It's considered of all ages. That number is 1-800-422-0009. And it's not so much just about suicide any longer. We make that phone call. That hotline number is available. If anybody's going through a rough time, it does not just have to be about suicide. It could be about, mom and dad's arguing. It's 2 a.m. I can't take this anymore. I need to talk with someone. You can talk with them. If you're feeling bullied, you can call that number. Again, it does not have to be about suicide.
Okay. All right. And then we also have the Eastern Shore Mobile Crisis and Eastern Shore Resource Helpline. That is, I always like to say, that is manned. It's here on the Eastern Shore, and it's manned by local Eastern Shore people. And somehow I think sometimes that can be good and bad, but I do think it's nice to know that these are local people helping local people.
Who are trained, right.
Who are trained, yes. And it's
Right.
1-888-407-8018, and that is the Eastern Shore Resource Hotline. And they can also, if necessary, send out mobile crisis teams that can help if you have a crisis going on in your business, in your home, even I believe the schools they'll go to if they're called. But anyway, they're a very good resource to have, and that's an important phone number, which we will repeat a little bit later. Now, though, if you don't mind, Rob, I'd like to switch it a little bit and tell us a little bit about the assessment that you do in the school system itself, and about your assessment that you developed, if you would.
Okay. Well, not anyone that talks about hurting themselves would receive that assessment. I mean, it's taken in triage initially, and if the route to go is to use, like, this is a little bit more than just saying it out of anger.
So that means, so who would be doing the assessment? So if you say a triage, you're in the hospital?
No, that could be done in the school setting. It's done by people that have received. I train them
Okay.
of what questions to ask
Okay.
leading up to, like, initial screening,
Okay.
to help, I guess, what direction do I go? What direction do I need to go into? And taking, I mean, there's common sense also involved in looking at pre-K and K, because sometimes
Okay.
that's said. However, that's still looked at very seriously. So the assessment itself started in 2009, and it was normed as a validated instrument, and it was initially normed or validated on 318 mid-Atlantic outpatient setting, school setting, children and adolescents from ages 7 up to age 24. And it looks at basic demographic information. It looks at, family. The next section is looking at family contact information, because it's important to look at the contact information before you meet with someone, if you can at all coordinate that, because sometimes somebody that's thinking about hurting themselves is irritated, they're angry, and if you ask what their mom or dad's cell number is, it could be potentially throwing gasoline on a volatile situation to make things really worse. And in the past, at different sightings around the country have had things happen where it just made things worse. So it's good if you can at all possible have that information available before you meet with someone, would be great. And then the third section is looking at one of the initial questions is, and one of the things that it's very difficult to ask is, what is the icebreaker question to ask when you're meeting with somebody thinking about hurting themselves? And so it's hard to do, and just that simple beginning question can lead you on the right path of having a good interview, building trust and rapport with that child, or it could make them like you just would never understand. Same thing with adults. So it kind of have some innuendo questions like, can you help me understand what's going on right now? Basic, bland question, no salt, pepper,
Right.
lettuce, tomato, to that simple, straightforward. And the same thing with the adults. And in the manual, it gives you several other options to use. And then it comes into you're looking at mood stability. You're looking at, how, are you having a hard time keeping up your emotions, over the course of the past year, last couple days, last week, and you're scored on that. And looking at the initial question, like how much stress is in your life also right now? And again, looking at the age appropriateness of that question, looking at somebody very young,
Okay.
Can you help me understand, how are you feeling really sad? Is there a reason why you're feeling really sad? Like where's the sadness in your belly? Or
Right.
and older kids, we ask, what, that anger that's inside of you, where does that all come from and how long ago? And then it gets into what's a scale. And this gets into the protective factors, the syndemic pieces. And so you're looking at the reasons, tell me, what keeps you living? I mean, what keeps you going? And you're looking at protective factors. So I want to graduate high school. I want to get a job. I want to get married. I want to have children. I want to have a good career. I want to make sure my dogs are taken care of. I want to feed my goldfish. And so tell me some reasons why you want to die. Are there any reasons right now why you want to die? And that is a scale, and we usually have 5 slots for each one, and we look at that scale. Sometimes I have no reason to die. I just said that, And so you're already starting to fish around to see where you are cognitively with that thought process. Like how far along are you in this process of leading up to being identified for today? So you find a lot of different kinds of things in that category. I just wish I was dead. There's nothing and there's nothing in the protective factor, but there's reasons in the wish to die. It's a little scary, kind of supersedes things, puts you in a different category. And then you get into 10 questions, and those 10 questions is, how much stress are you feeling in your life right now? Like, what's going on in your life? Okay, so so you said that you were really stressed out a lot lately. Where's this coming from? And you find, oh my God, I have all this testing going on. I want to get into this college. I didn't get into this one college. There's so much pressure on me. Or, I don't know what I'm going to do after graduation, which is typical with the anxiety piece. Nationally, this time of year with some of our juniors and seniors, stress, I don't know how I'm going to pay the bills. I don't know how I'm going to do this. I just got laid off. I don't know how I'm going to take care of my kids. And, so then how much psychological pain, how much pain is inside of you right now? Like on a scale of 1 to 10, it's a Likert scale, 10 being the worst, so 1 being the least. And so you're looking in each one of these 10 questions that I'm talking about now is weighted with a point system on the right. So that pain, so where's that pain coming from, and how long have you been feeling this pain? Have you ever felt this pain before? So that one question leads into a lot that's well described in the manual.
Okay.
So have you ever had thoughts about hurting yourself before? Within the past year, within the past week, within the past couple days? So when was the first time you had these thoughts? How long ago? What was going on in your life at this time 5 years ago when you first initially had these thoughts? Like what happened then? And then you're looking at, so how recently? What keeps you going? How come you haven't had these thoughts? When you had them 5 years ago, you had the same problem now. How come these thoughts didn't creep back in? What's going on? You just said this, and in question 1, when we talked about, the reason why you were identified, because you said that you were going to hurt yourself, and here you're saying you're not having these thoughts recently. So help me understand, where are you right now? Again, you're looking throughout this assessment tool, you're looking for contradictions,
Okay.
You said you were here, but then you're not here. So it's either one or the other. So where are we? A lot of people, regardless of age, that have received or considered or perceived to be chronic and having suicidal thoughts, this is not their first rodeo with an interview. And so they know what would happen if they do say that they are having thoughts or have been hospitalized.
I was wondering
So-
about whether some people.
So you have to be a little one step ahead and say, and look for those contradictions. And that's how this assessment is open-faced. So it's set up for us that are trained to find those contradictions, because it's either one or the other. And so the rule of thumb is, when you're doing an assessment, is you'd rather be damned for doing them for not doing and overlooking these
Right.
innuendos and contradictions, calling someone out for not lying, but they're not being truthful with you, or they may be confused. It also depends on their psychological state at that time, because you don't know what they're beginning to show signs of.
Okay.
Because regardless of the setting, whether it's an outpatient setting, you can see the beginning signs or early onset of schizophrenia, where you see some things that are just more so related to being psychotic with some different external kinds of responses.
Okay.
So, taking consideration, but on average, and then you're looking at, so have you ever attempted suicide? Again, one of the greatest predictors of futuristic behaviors is looking at our past behaviors.
Okay.
And that's across the board. So you had these thoughts before. You tried to harm yourself several years ago. You're having these thoughts now, and now you're saying you're not or haven't recently tried to kill yourself. And I like to ask the question, so why not? And they sometimes will look at you, what do you mean, why not? You want me to kill myself? No, because I'm looking at, what are these protective factors that are leading you not to kill yourself? When just 2 years ago, these same issues caused you to attempt suicide. So why not now? What's different now in your life? Where are these protective factors coming from? And so, do you really want to die? Do you really want to kill yourself? And so, what we look at when we look at a lot of research that's out there in suicide assessment, if I'm not trained as a mental health practitioner, which we know most mental health practitioners are not training across the board, no matter what level of education or how many letters we have behind our names, is that we, like everything else, and as Maslow, we avoid pain. So one of the things I want to avoid if I'm not trained is, I don't want to ask you if you want to kill yourself, because that's a point blank question. And so if you are, what in the heck am I going to do? What am I going to do now, because I'm 100% responsible, even though we're already responsible.
So you're saying we avoid that question?
Most of the time, that question in suicide assessment, it's well documented. Do you want to kill yourself? Very simple question. There's no ifs, ands, or buts, because we're afraid of the answer, because we're not trained. So, and so the questions go on to risk-taking behavior, experimental use with drugs or alcohol, and those kinds of things.
Okay, so let's take it now a step further. You've done the assessment. You have determined that person is in imminent risk of making an attempt. Resources. So what do you do?
Well, that'll put you in a category of so the highest score you can get is 27. So 17 to 27 is imminent risk. And so what do you do? So what do you do, whether it's in the school setting or an outpatient setting? Looking at the resource, if you're imminent risk, you probably should receive a much further evaluation. And at the hospital, they do a much more in detail evaluation, and then they also do a physical. So they do a blood draw. So they're looking at are these responses, or is there any drug use involved along this process? Or if you are taking a medicine or prescribed medicine, psychotropic medication, are you not taking your medicine? So the blood levels will indicate and could take us to a different trajectory than what we initially thought, because we're just seeing smoke with a good chance there's a flame there that's going to come out. So a more in-depth evaluation in a hospital. Again, the hospital is no great. It's nothing magical about a hospital setting, and most chances people that are sent to the hospital are not further kept at much more at an inpatient setting, because usually and the sad part about it in the country, including here we are on the Eastern Shore and up in Maryland when I worked at Johns Hopkins, the average wait in the emergency room is anywhere from 4 to 7 hours. So on average, if it's not busy, because there's so many other people there. If you went in with chest pains, though, you would be seen instantly. So then why do we discriminate in a hospital setting? And we do.
Right. I know you don't say that. I know you don't say that lightly, because I know we've heard stories of people, going, with serious concerns about a suicide attempt, and they go to the hospital, and they are there hours before anybody ever sees.
And if they're children, they are open to whatever comes to that door. I mean, I remember sitting in the emergency room with a child, and somebody would come to the ER just out of it on drugs, throwing chairs, I remember with their parents, and or somebody. We had a construction guy come in and holding the cup, and he had two fingers in that cup that were sticking out, and it's like, oh my gosh! So you don't know what's going to come through that door,
Sure.
because they had driven themselves with their supervisor, so you don't know who's going to come through that ER front door, waiting to be evaluated hours and hours later. And so the options are, of course, we have to follow through if imminent risk, go to the emergency room, unless if we can divert that. And so the divert piece is if the child's already being seen or has a psychiatrist or has a therapist, that we can get them in as soon as possible with that psychiatrist, as long as the parents are in agreement.
Okay.
As long as there's no extreme urgent, like, wait a minute, no, this child needs to go to the emergency room. But if we can divert that, because the average cost in the emergency room is a minimum $1,400.
Wow.
So, and not everyone has insurance.
Right.
So that's a major cost, 4 to 6, 7 hour wait. And by the time the child's even, or the adult's even seen, that crisis could have resolved itself.
Right.
So we try to divert that as much as possible, having received the training that we provide, because you have to follow through when somebody's imminent risk. Sometimes, though, in a setting, you have to get police to help out. You have to get our ambulance or emergency medical response to come and help. Parents, 99% of the times, are very cooperative and incredible, and it's sad to call. It's really sad to call a family a cold call, either for an outpatient setting or from a school perspective across the shore or in the state or nationally, and talk about, we identified your son or daughter as having suicidal thoughts, and how devastating that is. Wait a minute, I had no idea.
Right.
And so that response back is usually defensive,
Sure.
but usually resolves itself to come back to thank us,
Okay.
no matter what school district provides assessments. Not every district provides suicide assessments, which
So
is
I know Talbot,
sad.
I know
Talbot,
you do.
Caroline does, Queen Anne's does. I'm not sure if others on the shore, because a lot of districts will just assume to find that, identify somebody that's maybe having thoughts or said something or identified as having thoughts of hurting themselves, and are just sent to the emergency room, which is sad.
Right.
It's really sad, because it's a small number, a very small number. And so to do a quick triage and an assessment to determine the course of action, or the best course of action based on research and based on any sort of assessment. I want to preface this because there's not one assessment that's out there that's 100%. And so what we find is our guts are more accurate than any assessment.
Oh, very.
Because sometimes you'll find very low risk, but your gut's saying there's no way this child definitely, or this adult definitely needs a further assessment, because things just aren't adding up here.
Right.
I would feel much better going through and getting a more intensive evaluation. That's very rare that happens, but as professionals, we need to follow our gut. And hopefully our gut and our assessment outcomes are on the same page.
Well, very good. I've enjoyed.
I hope I answered that.
Yeah. Yes. Yep. You've been great. You've been great, and a lot of good information here. And then, so I probably need to start wrapping it up here. I know we are lacking resources on the shore, so I know that is a real issue. It's an issue where is it a federally designated? What's that term? Do you know the two?
Rural.
Well, we're a rural area, but underserved population. So we just don't have the resources on the beds on the shore. So if you take somebody to the hospital for mental health treatment,
There are
and
options.
something,
Yeah, there are options on the shore and in Delaware.
Right. That's, I know that you
Sure.
have utilized and have recommended some folks go over to Delaware, because there's 2 hospitals over there
Yes.
that are very good.
It's Woodbridge and Dover Behavioral Health,
Right.
and we use Shepherd Pratt. We use Lower Shore, Mid Shore. Yeah.
Right. All right. Well, and so as we wrap things up here, and I was just wondering if you could recommend one way to, if there is a way to improve our ability to prevent suicides. Is there, just is there things that you can recommend? Is there? And I'm sure there's more than one.
There's definitely more than one, but probably common, which is most overlooked and is probably the most least expensive, is that, again, empowering our kids to ask for help on behalf of themselves or for others is because they know about this way before us as parents or as teachers.
Okay.
Or as trusted, or mental health professionals. The kids know about this. And so empowering them that if you hear of something, please, if you hear of somebody talking about bringing a weapon to school, bringing anything like that that cause harm to school, or somebody talking about, just wish I wasn't here anymore, I wish I was dead, but don't tell anyone. Kids know about this, and adults know about this. And 90% out of 100, well in advance, but they are lacking a confidence to share this information. And it's very important to empower our kids and adults to get help for their friends on behalf of their friends. We never use names. So if you came to me on behalf of a friend, we never say, well, Jackie told us. We just say, look, your classmates or your workmates, they care about you, they worry about you, and they just want to make sure you're okay. We know you're going through a difficult time. Let us help you. And so that's why your classmates have come forth and said, you know what, we really care about you.
Right.
We want to make sure you're going to get through this, and we want to help you.
So I think
Very simple.
So it goes back, I think, to even what at one point what everybody has said about, even talking about, the terrorism or, people that want to harm the kind of
FBI calls this.
See something, say
Yeah.
something.
FBI
So
calls
say
this
some-
leakage, but I don't like that word. I mean,
Yeah,
leakage,
yeah.
I mean,
But-
kids don't like that word.
Right.
you know?
But if they hear something or they see something and
Just let us know.
Let us know. Right.
Everything's in confidence, confidentiality, all those kinds of things, and we have a duty. But it's hard, and it's important to share too with kids or adults. If something were to happen, you knew about it, you'll have to carry this burden around with you the rest of your life. And you knew about this, but you did not say anything. Is it really worth it?
Right.
You
Right.
could have saved lives. You could be a hero. Let us know. You never brought into this.
Right.
Yeah.
Well, Rob, thank you very much for that. I want one more time. I want you to tell what the Maryland
A crisis hotline
crisis
number is.
hotline number is. So you go with that one.
It's phoned. It's manned 24/7. It's 1-800-422-0009.
Very good. And then I also want to reiterate the Eastern Shore
Mobile crisis.
Mobile Crisis and Resource Helpline is 1-888-407-8018. That number and those numbers are also on our website, Mental Health Association of the Eastern Shore, and that website is mhamdes.org. You can also follow us on Facebook at Mental Health Association of the Eastern Shore, where we will have posted these talks that we are trying to get done over the summer here. And anyway, I appreciate it. Very good, very informative, and we truly appreciate
Thank
your
you.
time, Rob. Thank you very much.
Okay.